Well, thank you so much. It's great to be here today. I'm Clay Alsbach. I work at LEAVITT Partners. We're a consulting firm based in Salt Lake, Chicago, and Washington, D.C. I'm out of our D.C. office, so it's great to be here today, and just look forward to the discussion. So with respect to what I'm going to speak about, the brave new world of value, I only have 15 minutes. I'll try to keep it under that. So I'll give just a quick overview on basically where we've been and where we may be going, especially with the change in the administration. From talking to folks around the country, I know there's a lot of uncertainty, especially given the movement in the American Health Care Act, around what the future of value is going to be and what it will be under President Trump. So, but I'll try to give a quick overview and some signals that we're picking up to try to help in alleviating some of that uncertainty. So with respect to where we have been, it's clear from the federal government and frankly in the state government level, there has been a tremendous commitment to value and pushing that forward. And as much as in the Affordable Care Act, I think the ACA gets, there's tremendous, and solid provisions in that. It actually started earlier, and I think that's an important insight with value in that there's a bipartisan commitment to moving forward on value. There were value policies pushed forward under the Bush administration. The founder of my firm, Mike Leavitt, who was the secretary of HHS under Bush, he was a big proponent of it and tried to push forward under President Bush. The Affordable Care Act, that was where, when you look at the grounding and what's happening at the federal level, really in the Affordable Care Act, that's where you see those provisions coming forward. One of the main ones you'll hear about is the Center for Medicare and Medicaid Innovation, CMMI. It is responsible for putting forward demonstration programs where folks like yourselves who are on the front lines are participating in value programs and alternative payment models. So that is where a lot of what we're seeing today is coming forward. As we know, the Affordable Care Act was a partisan exercise, so there were actually some questions going forward as to what the future of value was going to be. But I think that was really solved in MACRA, and I think on the panel we'll have some other speakers getting really into the nitty-gritty on MACRA. But with that legislation, which was the repeal of the sustainable growth rate and moving forward the quality payment program, what you're seeing is, from a legislative standpoint, from a congressional standpoint, is really the bipartisan buy-in on this move to value. And it is going to take Part B physician payment, which is one of the strong drivers of reform, and value is front and center in that, especially in the advanced alternative payment model pathway. So that is, as I'll go through in a second. And then there have been other efforts, and I'll get into this in a second, as to what from Obama, especially Obama HHS, as to their commitment to it. So first, MACRA, just a quick slide on this. As I talked about, the advanced APM pathway and even the MIPS pathway, which a lot of folks are going to be operating under, includes elements of value. But this is really where they're trying to drive the physicians, yourselves, into these value arrangements. And what we're picking up actually is MACRA is not only going to have an impact on Medicare, but what we're hearing from payers especially is that there is a need, a necessity from folks like yourselves who are on the front line to try to align some the measures and others that are coming forward in MACRA. So it's not only going to be MACRA and Medicare. These are, and what you're seeing in the advanced APM pathway especially, is going to drive toward other parts of the market to the extent it's not there already. And then when Secretary Burwell, who was in charge of HHS, she put forward these policies of trying to drive really all of Medicare into these value arrangements. So this was a huge drive, and that's why you saw in 2016 with the end of the Obama administration trying to move forward at really like 90 miles an hour to get as many models out as possible to really drive to these goals. But the question remains, what's happening in the private sector? I think, as you all have seen, value is also important in the private sector. These statistics that you're seeing in front of you, accountable care organizations. So accountable care organizations, obviously there was a big part of the ACA in putting forward ACOs. But as you see with this in front of me, they're basically a majority of the lives that are out there. These are data from 2016 are actually held in private. So it's not only federal government programs, there are also a lot of private ACOs that are moving forward. But the question remains kind of where are we going to go? Where are we going? And especially under the Trump administration, given all the uncertainty that's coming forward on healthcare, where you have to check your Twitter feed every 30 minutes just to see what the latest development may be. So with respect to that, as much as the AHCA is causing and may cause disruption and uncertainty, I think one area where it should not do that and will not do that is actually related to value-based payment delivery system reform. So the components of the ACA that I referenced, they're not touched by what the Republicans are doing in Congress right now, and they're not likely to be touched. And I think that's a really important piece here, because as much as if you're playing in the individual market or you have a lot of lives in the individual market or in Medicaid, you are facing a lot of uncertainty, at least with respect to these value programs and the commitment to value. That's pretty stable. Now, with MACRA, as I referenced, it was a bipartisan bill. So it's going to stick around. I don't think you can look to it and say it's going to be repealed or it's going to be undermined. There are strong champions of it positioned, especially on the Republican side. Dr. Michael Burgess, who was the lead author of MACRA, he's in charge of a key subcommittee that's basically any legislation would have to go through. So they're going to be looking to figure out how to make it stronger and how to make MACRA work, not how to take it down. Now, Secretary Price and Administrator Verma, as you look at the Trump administration, it has been slow in filling positions and in moving forward. And actually, some of that is because of the American Health Care Act and how it's dominated. It's really dominated all of healthcare, all the healthcare issues, and it's dominating a lot of the bandwidth from Secretary Price and Administrator Verma. And that has led to some questions, even we're in June, right, of the administration, arguably like 6 months in, and we're still questioning, what's going to happen. At least in their public pronouncements and in their private discussions, Administrator Verma and Secretary Price are committed to value. Now, the question remains of how they're actually going to do that and what that means, because they're going to put their own imprint on it. I think one key insight from Secretary Price and what he brings with him, he's an orthopedic surgeon, and importantly, he was also chairman of the Budget Committee when he was in the House. He was arguably the leading opponent of CMMI, of that Center for Medicare and Medicaid Innovation, when he was in Congress. And he was especially critical of mandatory programs and mandatory bundles. And so when you look at what's going to happen and how it may differ, value may differ from the federal government context, well, those mandatory bundles are likely to possibly not move forward. You've already seen delays in the joint replacement and the 2 cardiac bundles that were supposed to move forward. Those have been delayed until early January. Some of that is because they're still trying to make decisions and trying to figure out where they are, but some of that is pretty much because of Price as well, where he's been so critical of mandatory programs that I think the chances of those continuing in their current form, they're likely to be modified in some way. That said, they are going to move forward on value, and so the question is, how are they going to do it? What kind of imprint? Well, I think the first area to look at is the states. So whether it's under CMMI, which has the authority to actually, as they've already done, do programs under Medicaid, or under waivers that they may grant under Section 1115 under Medicaid, or 1332 waivers, which were put forward under the Affordable Care Act, which are bigger waivers on waivers in the insurance context, not in the Medicaid. You're going to see, where we think you're going to see CMS and HHS try to move forward these value-based and encourage states to move forward in value. The other part is really with consumers. As much as consumers are really, in addition to physicians, consumers will really drive activity in healthcare. They haven't been in these value programs. They haven't gone as far as they can go. So I think you can look to consumers being more, whether it's cost sharing or other elements of them sharing in the savings, for example, other ways to get them more involved. That's what this administration will try to do. As well as when you look at MACRA, obviously the advanced APM pathway is with a 5% bonus payment, is a very attractive place for physicians and clinicians to try to get involved. The issue, though, is that especially for specialists, there aren't as many opportunities. I think you can see this administration, whether it's in the proposed rule that should come out soon or in the final rule, or through this physician-focused payment model technical advisory committee that has been put forward under MACRA, that is meeting and has actually suggested models to Secretary Price. They're going to try to get specialists more involved and provide more opportunities for them to take advantage of this. Because I think folks likely would like to live in the advanced APM world, not in that MIPS world, where there's the burdens of reporting and others are pretty strong. This administration, as much as they're committed to value, is also going to want the private sector to lead and to continue to lead. Now, it looks like the private sector will do that, but they're going to be looking to say to the private sector, what are you doing to help put forward these relationships? How are you moving forward in your contracts, whether it's a plan to a pharmaceutical company or a plan to a health system? They're going to be looking at every single element, every connection to figure out how that private sector can help drive forward. And they're frankly, and this is the last point, they're going to really want to know what the private sector needs in order to move this forward. Because as much as value and everybody buys into it at the high level, and it's a great talking point for folks to get into their conversations, it's really difficult, right, to actually set these relationships up, and it's a significant amount of investment to set these relationships up. And as part of that investment and as part of that analysis, there are certain regulatory and statutory barriers that are preventing these from actually moving forward as quickly as they should. Some of those are related to the Stark Law. Some of those are related to anti-kickback. There are other regulations that are out there. So I think the administration and I think this, states, to the extent there are state issues as well, I think will look for opportunities to try to resolve these, because as you look, we're in that fee-for-service paradigm, and that fee-for-service paradigm with Stark and with anti-kickback and these other regulations and statutes that are out there are built in that world. We're really going to have to examine from a policy standpoint what needs to be done to move to that advanced, to that APM pathway, to that value paradigm, and allow it to succeed. So that's going to be a lot of hard work. I mean, there's going to be protections that are going to have to be put in place, not only for patients, but also the federal treasury as well. But those are all policies that are being developed right now. So one thing I would encourage is to continue to be involved and continue to press the policymakers, whether at the federal or state level, because I think there is an open door, and especially as you're arguing to trying to move to this value-based paradigm in order to allow you to do that. So with that, I'll close, and I'll invite my another panelist to come forward. So thank you.
Thank you very much. Good morning, everyone. To be clear, it is Johns Hopkins Medicine, which is the formal alliance between the Johns Hopkins Health System and the Johns Hopkins University School of Medicine. So it is that alliance. So if it were just the School of Medicine, it would only be half the work. And so it's all the work involved. I'm here today to talk about an example that Clay was suggesting that states might take to address the question of value, and it's a approach that Maryland has taken now for the past 40 years, and over the last 3 years have done variations on it, and it is perhaps an object lesson for the direction states may be moving. So Maryland has set hospital rates since the mid-1970s. The Health Services Cost Review Commission is an independent body established by legislation. There are 7 members of that body. Full disclosure, I am one of those members of that body. And the question would be, is that a conflict of interest for me to serve on that body? And the answer is absolutely, it's a conflict of interest. But the enabling statute envisions having 3 of the 7 members be people from the provider community, so that provides a degree of input. I have to recuse myself on matters directly related to Hopkins, but I can give a perspective what the view of the hospital field is and physicians to the various work. It's described as a public utility model of rate regulation, and the Commission serves as both a watchdog and a regulator. Hospitals in Maryland have been waived from Medicare payment methods. This is called the Medicare waiver since July 1, 1977. And here is the interesting concept. All payers in Maryland for hospital services pay at an individual hospital the same amount for the same service. So think for a moment that if you have a gallbladder removal at Hopkins Hospital, it is the same that Medicare will pay, Medicaid, commercial insurance, the uninsured, HMOs. They are all being charged the same rate, and they are all paying on the basis of those rates. Now, the rates at Hopkins Hospital are different than they are for Bayview or for Suburban or for Mercy Hospital, but for all payers paying on the basis of the same rates. And it is indeed unique in the country. We moved to a global budget model that I'll talk about in a moment in 2014, but the basic structure of regulatory structure remains the same. Now, what is the value of an all-payer system? Why would the state want to do it? Well, cost containment has generally worked over the 40-year period of time. I'll describe in a moment how we fared over the first 3 years of this new experiment. It provides for an equitable way of funding uncompensated care, and while that is less of an issue now in the post-Affordable Care Act world, where insurance coverage has expanded considerably, there are still a sizable portion of the population without health care coverage at all, and it makes sure that we have no hospitals of last resort in Maryland, because included in the rates that the Commission sets is a reasonable level for hospital uncompensated care. It's a relatively stable and predictable approach for payment methods, so hospitals generally know on the revenue side of the equation what their revenue is going to be, and they can focus their attention on the cost side of that ledger. All payers participate in graduate medical education funding, so that's something, again, in an academic medical center we care about. It is a fairly transparent system. That is to say, the information that the Commission has is generally in the public domain, and so we have information about our competitors. They have information about us, and it is a much more open and transparent system. The state has been a leader in linking quality and payment. There is local access to regulators, and generally speaking, it has avoided the cost-shifting problem that happens everywhere else. You're familiar, Medicare and Medicaid pays roughly Medicare pays roughly 90% or 85% of costs, much less what your charges are. Medicaid pays in the 75% range. Hospitals shift that cost over to the private sector, and so the private sector ends up paying quite a bit more. In Maryland, that is basically eliminated, and there is a, as I said, an all-payer approach. So what is this new model that we're talking about? And what did the state commit to? Well, essentially, we negotiated with the Center for Medicare and Medicaid Innovation, Clay mentioned, CMMI, and essentially said to them, we think that if you come to a model that implies all payers on a per capita basis to take a look at holding overall hospital spending, that you more rapidly bring about the type of delivery system change and improvements that if you focus on only one payer. And so this is really an attempt to move from volume to value. I know an overused term, but in this case, at a statewide level, the state has committed to it. We have committed, for example, to holding all payer global budgets for hospitals to a long-term rate of growth in the state economy. That's about 3.58% a year that we have committed to, holding hospital spending to that level. We also committed to having 80%, at least 80% of the revenue in some form of a global model by 2018. We also committed, because this was Medicare, to saving specifically for the Medicare enrollees. And so we committed to producing $330 million in Medicare savings, cumulative Medicare savings, over the 5 years of this model. And that equates to beating the national average by about 0.5% a year. So whatever the Medicare hospital spending per capita for A and B, hospital spending per capita was, we agreed to hold it to that level, less 0.5%. And it's important to understand that for Medicare, hospital spending represents the majority of overall spending. In fact, in Maryland, hospital Part A and B spending represents 55% of the total cost of care for Medicare. We also had a total cost of care guardrail. So CMS, or the Center for Medicare and Medicaid Innovation, was worried that if the state were to hold down hospital spending, would we see a growth in non-hospital spending that would swamp those savings. And so they wanted to build in a guardrail, not a formal test, but at least to be sure that we weren't spending. Now, the state expected that some non-hospital spending would go up, but that the spending in hospitals would not, the savings that would be generated from hospitals would not swamp that growth. There were also built into this a whole series of quality metrics to be sure that while we were doing this, hospitals were not skimping on the quality of care. So, and finally, there was an expectation that over the course of time, the state would develop and move this model to a total cost of care model by January 2019. So we would look not just at hospital spending, but non-hospital spending as well. So how have we fared? Well, on the all-payer measure, you remember 3.58 was the rate of growth in per capita spending that we anticipated. In fact, for each of the first 3 years, we grew for all payers, not just Medicare, but all payers, hospital spending, well less than that. And in fact, over the course of that time, generated savings for Medicare, which was supposed to be $330 million over 5 years, over the first 3 years alone, generated $538 million in savings to the Medicare program. So it appears as if, at least on the financial metrics, that the system has worked well from that perspective. The quality metrics that have been developed also show improvements. Maryland, which had a very high readmission rate relative to the rest of the country on Medicare, in fact has had its readmission rate decline much more rapidly than the rest of the country, and we're on target by the end of the 5-year period of time to reach the national average in readmission rates. And in hospital-acquired conditions, those rates have fallen an astounding 46% over the first 3 years of the demonstration program. So we're beginning to think about what this new model might look like. How is it that we move from a hospital-based model only to one that incorporates other payers? And again, Clay mentioned MACRA as an important element of this. And because of MACRA, we're now beginning to see ways in which we can design and develop state-specific components, voluntary activities, whether it is around bundles, or activities regarding primary care medical homes or other forms of risk-sharing arrangements, to link the hospital model to various physician models to make them what we say is MACRA compliant, that they become seen as an advanced alternative payment model with some meaningful level of risk associated with it, so that we can qualify as many physicians in Maryland as possible for the 5% MACRA bonus. Our goal here, again, is to hold rates of growth in total Medicare spending to some reasonable level, and one that is achievable. And we are in the middle of negotiations with the federal government on that. And indeed, one of the advantages of being in Maryland is I will in fact be at CMS this afternoon talking about that. So why wouldn't everybody want to do this, right? It seems like a great idea. I am not here to proselytize. I'm not here to suggest that everything is perfect, and indeed there are things that are, in particular, need to change in this model. For example, the Global Budget Revenue Agreement, the agreements that individual hospitals have with the Rate Setting Commission, were developed based on historical levels. And so at least we know our base that we started with was relatively common to us. It was not based on something different from us. This is not a capitation model. This is still a underlying payment is still fee for service. Volume changes are allowed, and so while we talk about it as a global budget, in fact, those rates will and the charges will vary over time for market shift changes. And there has been some commitment on the part of the state to adding infrastructure funding, because to be able to do the type of care transformation, providing services to patients in their community, to facilitate transitions of care from inpatient to outpatient to avoid readmission, requires some additional investments, and the Commission has funded that. And then finally, transfer cases have to be treated differently. Again, you can imagine a place like Johns Hopkins does receive a fair number of patients who are transferring in. They have to be treated outside of this global budget arrangement. So the basic structure is generally fair, but we think that there are challenges in this specifically as it relates to academic medical centers. We think that there needs to be much more explicit funding for innovation activities, and certainly seeing things that are being developed in cardiology and in other fields that are on the cutting edge of development are not being adequately funded. Outlier adjustment would need to be incorporated, and we're seeing, as I'm sure many of you are, very rapid increases in prescription drug prices and the cost of medical devices that, again, I think are unique to academic medical centers. The market shift itself is not sufficient. We have actually seen volume growth, in part driven by the expansion of Medicaid. Maryland was a state that expanded its Medicaid program, and we saw a fair amount of growth there. That has not been sufficient. And alignment of non-hospital providers. We think that is going to be through MACRA to try to do it in a way that covers all payers. And as I say, we're in the midst of those phase 2 negotiations. And if you invite me back next year, I can tell you how they turned out. With that, I think my 15 minutes are up, and we'll wait for questions to the very end unless there's something burning at the moment. Thank you.
Good morning, everyone. If you're not familiar with MedAxiom, we are a membership organization of heart programs. We're actually around 400 heart programs in the U.S. and work with our many members on various initiatives, particularly looking at data and allowing them to benchmark with each other. And since we're in Baltimore, I thought it would be appropriate to share a Mark Twain quote because we're in an era of maybe unprecedented change in healthcare. So as Mark Twain said, I'm in favor of progress, it's change that I don't like. So when we talk about alternative payment models, we're really talking about some attempt to move away from traditional fee-for-service medicine. And that can take a variety of forms, one of which would be shared savings, where the organization is able to produce cost savings and then is given a portion of that back from Medicare, or is able to share a portion of those shared savings with providers. Bundled payments or episodic payment models, which we'll talk a little bit about. Shared risk, where you're really looking for the provider community to almost become a pseudo insurance company and to begin to share in some of the outcomes and cost risk with a defined population. And then it never really went away in some parts of the country, and it's beginning to reform. There's certainly an alternative payment model associated with capitation or forms of capitation. Earlier we talked about MACRA, and that's certainly one of the major changes. So if you're not aware, 2017 is the first year that most physicians are participating in MACRA, which will determine how much they're paid by CMS in 2019. And as it relates to alternative payment models, you have two paths. You've got the MIPS pathway, and then you've got the alternative payment model. And so CMS has already designed a number of alternative payment model programs for people to participate in. And if we look at those, they range from pay for performance on the left side, you might call that alternative payment or value light, and again all the way over on the right side to full risk. And in 2018 they'll be introducing two new alternative payment models. One is the APC Plus program, or ACO Track 1 Plus program, which is intended to be a kindler, gentler way, if you will, of health systems to enter into an ACO arrangement with a little bit less downside, but as well a little bit less upside potential. And then there's an oncology ACO that's entering in 2018. But the reality, well, CMS, I think, is seen as the driver of many of these alternative payment model concepts. Commercial payers are also attempting to embrace alternative payment models. And so whether you talk to Cigna or Humana or Aetna or Blue Cross Blue Shield, you'll see that they're all attempting to move away from pure fee-for-service medicine. Now, interestingly, most of the time what they're proposing is a fee-for-service based model with some kind of shared saving incentive, maybe a little bit of bundled payment incentive. So they're still heavily rooted in the fee-for-service world, but most of them today would say that they're already at or near 50% of their medical payments being made in some manner that's not specifically or exclusively fee-for-service. So the big initiative right now with alternative payment models that most heart programs are paying attention to is the two episodic payment models that will begin January 1. And as Clay mentioned, AMI and CABG have been selected for certain DRGs and been selected for certain metropolitan statistical areas around the country. So this impacts about 1,200 hospitals, which beginning January 1 will be judged and ultimately penalized or rewarded on a 90-day episode of care. And the way that will work is the hospital takes the risk for that 90-day episode of care, and a reconciliation will occur. So everyone is still paid fee-for-service, physicians are still paid fee-for-service, hospitals are still paid on a traditional DRG basis, but a reconciliation takes place at the conclusion of a year. And what's interesting in this program, and it's a 5-year program, it's mandatory for all those 1,200 hospitals that fall into one of those 98 metropolitan statistical areas, is that it transitions from the hospital-specific performance to ultimately what is a regional performance. And so what you find is that hospitals that have a higher episode of care cost for AMI and CABG, at least in the early years, will derive a benefit from being a higher cost provider. But as time goes on, they'll be really at a disadvantage. Now, it's important to point out that CMS automatically in this program reduces the overall payment in the reconciliation by 3%. And so there's a savings to CMS baked in. And you might say, even if you do everything right, you're just trying to earn your way back to the 3% reduction. But you may receive a further reduction once that reconciliation occurs. So that's the episodic payment model initiative under CMS. We expect any day now that CMS is going to relaunch what's called the Bundled Payment for Care Improvement Program, also known as BPCI. You might call it BPCI 2.0, and that's expected to start in 2018. So BPCI, there are 47 DRGs that you can pick for this form of alternative payment model. If you're a cardiovascular service line, you're going to be interested in one of these. Now, these are totally voluntary, and so there already was a 3-year program of BPCI, so there are many heart programs around the country that voluntarily have participated in one of these DRGs and are being paid on a differing basis from traditional fee-for-service. It had its flaws, and we would hope that CMS has learned from the issues and criticisms that it received in round 1, and so we hope that version 2 will have improved some of that. But it's interesting to look at the comparison between the mandatory episodic payment model and the voluntary BPCI model. So under EPM, it's largely the hospital taking risk for that 90-day episode of care and the hospital having the financial risk in terms of penalization. It is able to engage either physicians or post-acute providers and engage them in some type of shared savings model. Whereas BPCI is totally a voluntary program. You can have different organizations serve as the initiators. It is DRG based, but it is varied in terms of the patient populations and targets. And it's got a few different flavors in terms of the different financial modeling, which we don't need to get into that detail. But specifically, I want to talk for a second about bundled payment. Bundled payment appears to be becoming the maybe seen as the silver bullet for healthcare, yet to be determined if it delivers everything that people expect it to. But the reality is bundled payments are proliferating. As I talked earlier, January 1, you'll see the episodic payment models, also known as bundled payments, launch for those 98 metropolitan statistical areas and 1,200 hospitals. You'll see bundled payments in BPCI 2.0, but you're also seeing commercial care carriers launch bundled payment initiatives. And where you see red dots on this map, interestingly, these are employer-driven bundled payment initiatives. So anyone here from the Seattle market? So Seattle has a large employer, Boeing, the largest employer in Seattle. And so Boeing said, we're not going to wait around for CMS or the commercial payers to launch bundled payments. We employ and pay a significant amount for health care. We're going to build a bundled payment methodology into our employee health coverage, and all providers who treat those employees and their dependents are going to be participating in bundles. So it's interesting to look at bundled payments proliferating. Chad showed us a slide, and this shows that ACOs are also proliferating, whether they're Medicare ACOs or commercial ACOs, but certainly ACOs are initiating forms of alternative payment models, and this is through the end of 2016. By this point, I think we would expect to see that there are well over 1,000 ACOs across the country. So what do you do if you're a cardiovascular service line? What do you need to do to be ready to be successful in alternative payment models? I write a blog every week, and so I talked about this a couple weeks ago, and I think there are 4 key competencies. There are many competencies that you'll need to do to be successful, but the 4 that I would say you need to focus on at your cardiovascular service line level are, number 1, effective governance, and that goes beyond just having a council of physicians and non-physicians who do some strategic planning, but really have a physician-led organization in terms of your cardiovascular service line. Second would be a culture of innovation. How do you really improve care? Third would be having access to actionable data, or better yet, maybe actionable information. And then fourth, the ability to partner with external organizations. So let's talk about some examples, brief examples. So a patient comes into the emergency room with chest pain, and when we talk about clinical innovation, the question is, will that patient receive a relatively consistent assessment and care pathway, or will it vary dramatically based on who the ER physician is or who the cardiologist on call is? What we find in most organizations is that it's still highly variable, but some organizations do a very good job of looking at evidence-based care and developing care pathways and care guidelines and making sure that they're beginning to reduce the amount of variation through data and their own internal learning. So this is a good scenario in terms of if your system can fix this degree of variation, you've probably got good clinical innovation. In terms of data, when you look at what's available, particularly for 90-day episodes of care, most hospitals have no idea what happens to that patient after they leave the hospital. But you'll now be at risk if you're in one of the EPM programs. So this is some data that we provide with some of the EPM members that we're working with, where the blue bar is the anchor hospitalization cost, and then the other colored bars represent whether they go to a skilled nursing facility or a long-term care facility. And you can see this is looking at hospitals in one particular region. You can see the degree of variation, not just in the anchor hospitalization, the blue section, but the degree of variation in terms of the post-acute utilization. And then this is looking at cabbage costs by surgeon. So obviously a large heart program, many surgeons, but it's interesting to look at not just the variation in cost, but the variation in total episodic cost and the utilization of post-acute services excessively for some surgeons and their cabbage cases, but yet not for others. So that kind of covers the EPM program. If you're looking at CHF, it's very interesting to also look at data, and what the data would show you is that if you're looking at BPCI, CHF appears to be the greatest opportunity, because right here it's got the largest number of cases compared to all the other BPCI options, but also it has the greatest degree of post-acute opportunity in terms of skilled nursing facility or post-acute providers. So the ideal would be that as a service line, you are going through a readiness assessment and looking at, do you have all the components in place in your hospital service line, and judging whether you're ready to take on alternative payment models, either on a voluntary basis or potentially on a mandatory basis. And then if you're really interested in a quick and dirty way, you can go to the MedAxiom website and you can actually pick out every hospital in the country and you can download your report. This is just one example of the kind of data you'll see. So this is looking at cardiovascular medical services, and we've aggregated the Medicare data into more of a dashboard format. So you can look at your length of stays, your average charges, your case mix index, and begin to understand how do you perform today and understand where you may have gaps in the future. And I'm out of time, and I think that's my last slide.
Good job.
Okay.
So thanks, Ben, and really a shout out to Jeff for having the vision to include this session in this year's ASC scientific sessions. So in the next 15 minutes, in speaking to the concept of value proposition and CV service line, I'm going to try to answer these three questions. What is the value proposition for the concept of a CV service line? If you have one, how do you define or improve the value proposition for your service line, with some specific comments about the challenges faced by academic medical centers? And then finally, since we're echocardiographers, what is the value proposition for echocardiography in a cardiovascular service line? In so doing, I really want to challenge you to think differently about the way you do business as echocardiographers, and also lay the groundwork for this afternoon's follow-up session. I also want to point out that all of these comments refer to very much moving targets. So let's start with the definition. In business terms, a value proposition is a statement that clearly identifies what benefits a customer will receive by purchasing a particular product or service from a particular vendor. And traditionally in healthcare, the only customer we thought about really was the patient, and so we articulated our value proposition in terms of high-quality care and patient satisfaction for people with established disease, typically hospital-focused and very siloed: cardiology, CV surgery, vascular surgery, and so on. Now we have to recognize that our customers are not only our patients, and by the way, patients with options, no longer a captured market, but the community in which they live, including those who do not yet have heart disease, referring providers, and last but absolutely not least, the people who pay for it. So we have to consider additionally, beyond quality and patient satisfaction, cost and population health. And IHI in 2008 sort of introduced this concept of the triple aim for healthcare: improving the population health, improving the experience of care, and reducing per capita cost. So what's the value proposition for a service line? Well, let's start with a definition of service line. So in general terms, this is an aligned approach across traditional silos. When we talk about CV care, this has to include inpatient and outpatient care, because approximately 70% of cardiovascular care actually does take place outside the hospital. It could and should recognize obligations to people at risk, not just people with established disease. Typically, the leadership is either a dyad or a triad structure. If a dyad, a single physician with an administrator partner. If a triad, you'd have a cardiologist, a CV surgeon, typically along with that administrator. By definition, service lines need to function as entities that are very patient-centered, and that's because they have a strategic and operational horizontal organization of CV services that are aligned, designed to avoid duplication, so that the patients experience better health care. Components are at a minimum cardiology and CV surgery, but you can see when you start to think outside the box, should include hospitalists, intensivists, CV anesthesiology, vascular medicine, so on and so forth, and should, in the broader sense of the word, also include the primary care physicians who care for our patients pre and post hospital stay. So in broad terms, what's the value proposition for the concept of a CV service line? And I would argue that it's really an ideal structure to meet the three goals of the triple aim. And summarized, if you like, into improved value defined as quality, ultimately measured as outcomes, divided by cost. At a more granular level, CV service lines can lower costs both directly and indirectly through improved quality of care, result in costs that are more predictable, more appropriate, more inclusive, and they provide a cost structure that's better positioned for payment reform participation, whether it be bundling or an ACO. From the quality perspective, these are good structures for better care coordination, appropriate use of resources, more patient-centric care, and arguably providing better outcomes. Now, if you have a service line, how do you define or improve the value proposition for your service line? And from a business perspective, there's sort of this concept that's traditionally what CV service lines, I think, have thought about, is that we will do everything for everybody. And the business people will encourage us to sort of try to think about exactly who we want to be. Do we want to be a solution shop where we will find out what's wrong with you? Do we want, therefore, luminaries in the field, high technology, research, niche programs, education? Or do we want to do what's called a value-added kind of approach to things where we will fix what's wrong with you in a cost-effective, patient-centered way? In this case, you need talent, but not necessarily luminaries, but you absolutely have to be efficient and you have to be patient-focused. Now, we often don't get the choice of saying we're going to be one or the other, but it's worthwhile exercise to figure out what parts of your operation meet the solution shop obligation and what parts of your operation are more along the value-added branch point. Regardless of those issues, Service lines, your service line must practice team-based care where everyone works to the top of their license. This is important for quality, but boy, is it important for cost. You have to be open to change. These are all moving targets. Every day can bring you something different. And as other speakers have already alluded to, you have to be data-driven. You have to be willing to measure yourself, and you have to be willing to respond. You also have to understand the financials, which can actually be harder than you think it might be, understanding costs in particular. But be tuned in to both the direct and indirect revenues. And a prime example, I think, here is the growth of TAVR programs. In the early days, the major source of revenue for TAVR programs was the indirect revenues related to traditional cardiac surgery, because the TAVR programs brought those patients in. Now that's changed, but even with the newer model, as an imager, I'm very aware of the fact that their role is critical, but they cannot be expected to cover their salaries with RVUs generated. If you need them to do this work, you have to figure out a way to take off from the indirect revenues, downstream revenues, and to use those to pay imaging salaries. At the same time, of course, you have to sort of straddle this divide between traditional fee-for-service and alternative payment models. You have to understand your customers. Now, patients, referrers, payers, or community, and this is probably an incomplete list. And yes, you have to focus on quality. But I would be doing you a disservice if I didn't really emphasize the importance of cost. You really have to pay attention to cost, because for many of your customers, that's the most important thing. And also you have to be aware of what we call the Yelpification of medicine, the impact of the internet on all of our partners in healthcare. Academic medical centers, the concept of challenges that they face has already been alluded to. But in broad strokes, these new customers reorder the measures of success that were formerly used, meaning reputation, research activity, and innovation. Additionally, the ACGME training approach is not really conducive to a service line concept. Our cardiology fellows are still handled through the Department of Medicine, even though cardiology doesn't belong to the Department of Medicine. AMCs tend to be specialist heavy, which makes them poorly positioned for ACOs, bundling APMs, and risk sharing. They typically have higher costs, and they also are more inclined to have underdeveloped cost accounting, billing, and documentation systems. Additionally, to align those goals with physicians can be challenging, because you've hired physicians into academic medical centers because they want to teach, they want to do research, and now you have to make them be interested in and derive professional reward from things related to quality and cost containment. And finally, of course, there's the medical school out there and the complexity of partnerships between academic medical centers and their university partners. A reminder that this is really happening in the real world. This was in this weekend's Wall Street Journal. The featured article addresses the way that even the Mayo Clinic is dealing with the challenges that it's facing as part of the changing environment. The headline being, Mayo Clinic's unusual challenge, overhaul a business that's working. And the article deals essentially with their cost containment strategies. So what's the value proposition for echocardiography? Why choose echocardiography? So probably all of us could easily come up with a list of benefits for echocardiography. And in the context of this presentation, I would highlight the last one. It's relatively low cost. But additionally, we have developed on our own initiative a number of techniques or tools for assessing and improving quality, including lab accreditation, credentialing for both physicians and sonographers. But let's rethink this. Let's think about who our customers are. Well, let's start with patients. What do they care about? They care about cost. They care about easy access, a positive experience, internet accessible appointment scheduling, for example, and perhaps internet accessible results. Do they care about new technologies? Maybe not so much. So what do we have to do? Of course, we have to focus on these patient needs. And since new technologies are very important to us, if we want that to be important to our patients, we have to educate them. The same is true for referring physicians, or for referring not just physician providers anymore. They want quick, clear diagnostic results, and they want patient engagement. So we have to address those things. And again, if we want to have them see value in new technologies, we have to educate there as well. And finally, the payers, certainly not last, but absolutely not least. We start by saying we have a relatively inexpensive modality compared to others, but does that obligatorily translate to high value? Not alone. We have to be tuned into using appropriate use guidelines to control utilization. I think with the transition to alternative payment models, including bundling for sure, we have to revisit this concept of appropriate technology. And maybe for some instances, a handheld pocket ultrasound is the way to go rather than a full-fledged in the echo lab echo exam. Efficiency, of course, is key, and you have to be willing to actively work to contain costs. So numbers matter. And in the time that I have, really not enough time to really speak to how IT can help. But without data, you cannot hold your own heels to the fire in terms of how you're doing, and without data, you cannot possibly improve. So it's not enough to sort of pat ourselves on the back and say we're absolutely wonderful. We have to have numbers that go with it, numbers to share with payers, numbers to share with patients and our other customers. So in conclusion, I would say that in a value proposition world, the CV service line structure makes sense. Building the value proposition for your service line requires that you focus on your customers and cost, and I would say that in capital letters, flashing lights, we have to think about cost. We, of course, have to continue to focus on quality, and we have to think about adapting to a constantly changing environment with conflicting priorities and understanding who you are. Are you a solution shop? Or are you a value-added kind of operation? And I would say echocardiography, because of all of the good things that we know to be true about this modality, will always be a part of a successful service line. But in the words of one of our newest Nobel laureates, Bob Dylan, I would say the times they are changing, and if you don't change with them, you may be in trouble. So with that, I will stop and thank you for your attention.